Arguably, paramedics are often asked to distinguish between situations that are emergencies and the ones that aren't. In the setting of acute presentations, the role of paramedics is to make recommendations for treatment or give advice on what the client's next step should be. The question that paramedics might need to explore is who is best suited to meet the client's needs and in what time frame does this need to occur. Traditionally, we've considered time constraints and the limitations associated with just pure clinical examination can make this role very challenging to fulfill. However, this does not alter the fact that these can be really high stakes decisions and can have severe outcomes for clients if paramedics make the wrong diagnosis or come to an incorrect decision. Before we launch into the world of clinical decision making with acute respiratory presentations, let's take a moment to reflect on how clinicians might make these decisions. The prescribed route for these decisions is to gather data, interpret the meaning of that data, and link it to a management strategy. The skills lie in knowing what data to collect, how to analyse it, and to have access to a mapping process to connect to the management strategy. In many settings, paramedics sift through the available data, run a thing known as an illness script from memory, and look for differentiating factors that might support a particular diagnosis. The process is described as bottom-up thinking, and it's the hallmark of working through low acuity issues. However, if we're to consider the higher stakes associated with our business and the time constraints that paramedics face, it might be better to look at the processes used in the emergency department setting. The similarity between paramedicine and the emergency department should be reasonably apparent. Arguably, they're more likely to see urgent cases with a higher probability of severe pathology. The emergency department process focuses on the primary complaint or the most worrying symptom and links this to an evidentially validated killer diagnosis list, sometimes called the not to be missed diagnosis list. Most differential diagnosis list applications and books include these killer lists when the differentials for a primary complaint or an alternative diagnosis include those with a high probability of a poor outcome, and sometimes when they're a rarer condition that might slip the memory. Using this process is an example of what's known as top-down thinking. As the clinician enters the clinical reasoning phase, they start with a finite list of things that need to be excluded or proven before a final diagnosis is made. I feel my job today is to convince you that you'll need to access and use these differential lists to succeed in clinical practice. So first, you'll need to know what's on this list, and second, what specific information you'll need to seek to confirm or to exclude these conditions. In other words, how to apply this top-down thinking. In addition, you'll need to know what further tests allow these diagnoses to be excluded or not. And if paramedics are in a position where they can't get these tests done in the field, knowing where clinicians can do this in a safe and timely manner is going to inform the recommendations that paramedics will make to their clients. Some existing aids assist with this process. There are several sources for differential diagnosis lists. Perhaps the most accessible is via applications such as Diagnosaurus. Now, I'm not making a commercial endorsement for this particular app, it's just the one that happens to be on my phone. The app would be available on both Android and Apple platforms, and it allows the user to look up a differential diagnosis list by primary complaint or by their assumed diagnosis. And one of the most valuable features I find about using these is that it automatically compiles this not to be missed diagnosis list for most conditions or presentations. Suppose an application is not to your liking. These lists can also be found in published textbooks such as Taylor's Differential Diagnosis Manual, and that particular one is available as an ebook in the ProQuest collection, so it's available through the library at Whitireia, and you can find the link for this in the lecture notes associated with this presentation. Another tool to help in this process are the red flag lists that are found in the CPGs. Now, this is not a differential diagnosis list or a killer diagnosis list. What it does do is list the findings that are linked to poor outcomes for any type of presentation. So what they present is the data that's actually required for top-down thinking. Paramedics need to routinely employ both of these processes during the data acquisition phase of clinical reasoning and use it as a must-include feature when documenting the patient's history and findings from the physical examination. Let's take the case of someone who presents with pleuritic chest pain. Now, this type of chest pain is that very sharp, most uncomfortable, but very localized chest pain that worsens with cough and any form of respiratory movement. Is often really severe and most uncomfortable for the patient. Now, the image on the left here is a screenshot of the differential diagnosis list for this type of pain. Immediately, you'll note there's a not to be missed diagnosis, and that is for pulmonary embolism. Now, this condition is usually caused by a blood clot that's obstructing the blood flow through one or more of the pulmonary arteries, and it can lead to a very significant pulmonary infarction and to death. We will be looking at illness scripts later in this session, but for the time being, let's assume that most illnesses have a somewhat predictable pattern of who gets it, what the risks are for them getting it, the time frame it's going to develop over, how it presents, and what's going wrong. We're shortcutting at this stage, but we will revisit this. The historical features and timeline for a pulmonary embolism often relate to air travel, prolonged stasis or perhaps bed rest, recent surgery, a patient who's already taken anticoagulants because this identifies the patient at risk from an embolic event anyway, or that they suffer from atrial fibrillation. If any of these features exist, top-down thinking would be to strongly recommend a trip to the emergency department for diagnostic testing. Now, the test that's going to be required is a D-dimer test, it's a blood test, and whilst not entirely specific to PE, if it comes back at a very high level, it's pretty indicative that something of a thrombolytic type event is going on. At this stage, I haven't even considered what the vital signs are or have even completed a physical examination. Now, obviously, I am going to do these things and I'm going to record the outcomes. But the decision to recommend transport was made on the basis that I was unable to exclude the presence of the pulmonary embolism. So, let's take an even closer look at this process. We know we're presented with a patient who's got pleuritic chest pain, and I'm assuming that I've completed the primary survey and I've corrected any issues arising from that. The next step would be to acquire some data. And you might recall from previous papers last year that we examine the primary complaint and then the medical histories, acquire some vital signs, and then complete the appropriate physical examination. Now, we use structures such as OPQRST or Socrates to investigate the primary complaint, particularly if it's pain. So let's look at how a paramedic might document this particular investigation. I've used the OPQRST structure and I've included the associated symptoms. In this case, it's the absence of cough, which is a pertinent negative, but we'll talk more about these later. So at this stage, I've already put on my top-down thinking and put the pulmonary embolus on the radar until it can be proven not to be there. I play the remainder of my illness script through my head, and it's telling me that people who are likely to have this are those that are on oral contraceptives, have had recent air travel, have been bed-bound, recent surgery, they're on anticoagulants, or they suffer from atrial fibrillation. So let's move on and see how that got documented. In this case, the patient is using oral contraceptives, a risk factor that means I cannot take a pulmonary embolism off the radar without diagnostic proof. But as you can see, I've still had to ask the other risk factor questions. So you will see that I've recorded the pertinent finding and also provided commentary on the common risk factors that are not present. Recording the absence of an essential feature of a disease is called a pertinent negative. To reiterate the point from the previous slides, differential diagnosis is a list of plausible conditions that can be attributed to the signs and symptoms that are exhibited by a patient. These lists can be large and unrealistic to manage, but the way forward is with top-down thinking and excluding or recognising those conditions that are associated with increased morbidity or mortality. Differential lists can help mitigate against search satisficing, or in simpler words, the tendency to call off for a search for a diagnosis once the first one has been found. The not to be missed diagnosis list places the most important and plausible alternatives to the first decision on the radar. It also prevents overlooking a second illness or injury, a crucial element of thinking, particularly when we're managing trauma cases. Differential lists also mitigate against availability bias. Most respiratory conditions are benign and self-limiting, as is the case in, say, a viral upper respiratory tract infection. And for children, these presentations are very common. The availability bias occurs when recent experiences with a common disease may inflate the likelihood of it being our first choice in diagnosis. Conversely, a condition may be underdiagnosed if it hasn't been seen for a long time. In other words, it's less available to our memories. The not to be misdiagnosis list will contain those rarer or more easily overlooked conditions that are more dangerous and are associated with adverse events if they are forgotten or they're overlooked. It is improbable that a patient would have all the conditions that are presented on the differential list. The next step is to explore the elements that can help discriminate between the conditions on the list. And by way of example, let's consider the presence of a chest pain with some fever and cough. The differential diagnosis for this includes an upper respiratory tract infection and community-acquired viral pneumonia. Now, one of these is a benign self-limiting condition that poses minimal risk to most patients, while the other poses a significant threat, especially to the very young and to the very old. To differentiate and to be able to come up with a working diagnosis, paramedics need to establish which of these is most probable and which can be most safely excluded. Now, we do this by comparing the differentiating features in the illness scripts for these conditions, and this is what we're going to explore next.